All right, so presenting for us today, we have Cynthia Kim. She's a licensed clinical social worker and director of behavioral health at the University of Hawaii Family Medicine Program. So I'll go ahead and let you take over. Let me get your slides pulled up.
Thank you. Thank you for the introduction. I think before I kind of go into our objectives and things like that, I just want to acknowledge or put out a acknowledgement that everybody has been through a lot recently with the weather, to put it mildly. And some of us were directly affected, some indirectly, but we're kind of all reeling from the intensity of the past couple of weeks of really awful weather that we've had. So I just want to acknowledge that and just kind of say, I'm hoping everyone is doing as okay as possible. And if anyone needs help or support, there's a lot of us trying to organize within our communities and figure out how to link people to support. So please don't be afraid to reach out if there's anything that would be helpful for you or your loved ones or your friends or communities. Um, the title of my talk today is "It is what it is?" question mark. And this is going to be less of a formal presentation. I'm hoping to kind of get through my initial slides rather succinctly and sort of provide a little bit of a lens or a context. And then I'm really hoping there will be some rich discussion. And I want to hear from you questions that you have about the subject matter. And I'm hoping that maybe we'll have some opportunity to talk a little bit about micro practices or answer questions or just sort of open up a little bit of space for people to maybe debrief about some experiences that they've had along these lines that you might still be struggling with or know colleagues that have been struggling with. So when I asked, when I was asked to present today, I said, great, what do you want me to talk about? And something that came up during a previous presentation that I was part of back in October was this idea of the new normal of life with COVID and helping people accept. And I think it was Dominic who said, how do you help patients accept the reality? And that's a trick question. Go ahead and next slide. I have no disclosures, financial or otherwise. So what are we going to do today? We're going to reflect on the shared mental model that we started to sort of talk about last time I co-presented. And if you weren't here for that, maybe there's a recording. If not, I'm happy to share slides or talk to you about that. But there was this sense of like, this is beyond just the medical and the physical. There's a spiritual element to all of this. There's definitely psychological elements to all of this. And all of that is also neurological, by the way, so it still is biological. So how do we work on shifting our shared mental model about what's really going on with people? And how do we help our patients understand what they're experiencing through that lens of this is very much behavioral and mental health as much as it is biological and physical? And then I'm going to give you the secret to life, the universe, and everything, which, if people are not on here, they are missing out big time. There's an almost magic formula for helping patients with what I would characterize as a form of grieving. And we'll talk more about that in a second. But it's actually not magic. It's still science. It's still neuroscience. So, and then I'm hoping, like I said, to open up some space for discussion, questions, reflections, comments, angst, woes, whatever we have that we want to kind of process together. Not that I'm going to turn it into a therapy session. I just got out of a therapy session, so I'm still in that mental model myself. And so you're going to get to see how the sausage is made. You're going to have access to my innermost thoughts, like it or not. Sorry. Next slide, please. So what is the new normal? Previously, we talked about it. It's undeniable. There are huge, some subtle, some glaringly huge and obvious biopsychosocial consequences to experiencing, I think, any form of COVID infection, but particularly this lasting phenomenon that we've come to refer to as long COVID. We know there are cognitive changes on a neurological level, other physiological changes that affect mood, behavior, and certainly have an impact on functional quality of life. Some of those are really apparent and can be quantified pretty readily or measured and dealt with objectively and specifically and discreetly. Others are more invisible. And back in October, I sort of referenced that along with things like fibromyalgia, autoimmune conditions, forms of disease and illness that affect us mentally, emotionally, and physically that are not readily visible to those on the outside, right? So I can look perfectly fine, but if I'm suffering from complications due to lupus, for example, I might not always be in an active disease state with regard to those complications. So it might look like I should be doing okay. And if I'm not doing okay, there's a lot of value judgment that gets placed on why is this person not meeting expectations? And the harshest judges for that are always going to be ourselves. So I think our patients are coming into this game with not really the grace that they might need to understand that whatever their baseline was, whatever the normal was, it's a new normal. The baseline may have shifted radically. And some of that is, like I said, direct and measurable and apparent. Much of it is not. So we're going to reflect on that a little bit more in context today. And as such, we talked about how our standard behavioral approaches, mental health approaches, like targeting symptoms, might be incomplete. It might not be the whole picture that we need. So how do we go about effectively working with folks to accept? And acceptance doesn't have to mean liking. We'll talk about that too. We'll talk about radical acceptance for what can be really limiting functional impairment in terms of their state of health and mental health. Next slide, please. So if we're conceptualizing this, I think it's fair to think of any functional impact that someone is experiencing as a form of loss, right? Maybe it's loss in their baseline cognitive function. Maybe their working memory has been impacted. Maybe their energy, their fatigue level is making it difficult for them to find the motivation to do things as they would normally expect themselves to be able to do. That's a form of loss. And wherever there's loss, kind of like wherever there's smoke, there's fire, wherever there's loss, there's grief. The problem is that we are sold this myth that grief is a process that we can move through in almost a linear fashion, from denial to negotiating, acceptance, anger, all of those stages, right? The Kubler-Ross kind of stages of grief. And there's some truth to that. But what if a person is not dialed into thinking about this as loss and grief? Then they're not doing that grieving. And therefore, you can't accept what you're not dialed into in terms of how it's affecting you, right? At a metacognitive level, our ability to function may have changed so radically from what is expected. And expectations are very important because a lot of times expectations are not explicit, they're not clear, they're implicit. We'll talk more about that too. That impacts our sense of identity. Who am I now if I can't function the way I used to function? Our sense of self-efficacy, our sense of self-worth, all of those parts of our cognitive schema, our sense of who we are at our baseline may have shifted, and that cascades into multiple other layers of loss that at the very least is going to be disorienting and at the very worst can be disabling. So without intentional and structured processing of that in both the mind and body, because they're not separate, right? There's minimal chance of long-lasting relief or improvement. This is going to have a profound impact on any medical treatment that's underway, trying to improve this person's symptoms. And the more we dig our heels in and sort of resist acceptance of the new normal, the more our body is going to respond to that as a challenge that we're in survival mode. And that's going to continue that cascade of negative things that we know are problematic, right? Next slide. So what can we do? So much. And here's the kicker. The thing that underlies all of the medical treatment that some of you provide, the psychological treatment that some of us provide, whether it's psychotherapy, counseling, pastoral counseling, whether it's people seeking spiritual guidance, all of the things that we think of as intervention are predicated on this idea of the provider-patient relationship, right? Hopefully that sounds familiar. So for example, if we look at the research, on what kind of psychotherapy, for example, is the most reliable, the most useful, the most impactful, it has less to do with the actual modality, even though CBT is going to come up as evidence-based, and that's always a board question, not accidentally. It's either an SSRI or it's CBT. I tell my residents, cognitive behavioral therapy. There's a difference between evidence-based and why something works the way it works. And the thing that explains the why, and I joked about showing y'all how the sausage is made, it's not a secret. It's the doctor-patient relationship. It's the counselor client relationship. It's the psychologist therapy client relationship, right? we have to understand who we are in that moment in relationship with the other person in front of us, whether it's an in-person visit or a telehealth visit. Um, and we have to be able to tune into what's coming up for us and process that first and foremost from moment to moment in order to leverage that efficacy. So I can tell a person, you're depressed. I think that if you just get up and go for a walk every day at 6 o'clock, you're going to feel a little bit better. And then as you feel better, you'll be able to do more. And as you do more, you'll feel better. How I deliver that information makes a huge difference in whether or not that patient understands why I'm recommending that, whether or not they think that's going to be helpful themselves, and whether or not they're willing to work with me and partner with me to try to use that as intervention. So my delivery is predicated on my ability to flip the script for myself internally, and we'll talk about why I call it flipping the script. But it starts with simple things like language. For example, at a surface level, we can flip the script for ourselves and shift to person-centered, operationalized definitions of what we're working with. So when I talk about expectations and I talk about defining behavior, if I characterize a patient with long COVID symptoms as depressed and lacking motivation, they have decreased motivation, that's not very person-centered. I'm pathologizing to some extent there, right? Which is not going to be helpful for me, and it's not going to ultimately be helpful for the patient. I might document that in my note, but if I'm having a conversation with the patient, they're going to be likely to hear that as value judgment, for example. So if instead I can say, you're finding it difficult to get out of bed, if I can operationalize what decreased motivation looks like for that person in terms of whatever functional impact it's having, and then what is the cascade of impact from that? If I can operationalize that to being about mostly behavior, I can remove value judgment and I can open up a whole realm of possibilities for that person to find more motivation, to depathologize their mind and their heart about what they're experiencing, to empower them. And that's what this is really about. Language is powerful. This came up in our huddle today. I'll use this as an example. We had a resident, we were doing some loving kindness meditation at the end of our team huddle before our afternoon clinic session. And someone said, well, what do I do with this rage I'm feeling toward this person? I want to swear at them and let it out. And I'm just saying, I wouldn't say it to their face. I'm only saying it in my head. And I said, but did you know that even if you're letting loose, you're letting that F-bomb drop in your own head, directed at that person mentally, you're absorbing the toxicity. Your nervous system is going, ooh, what just happened, right? And believe it or not, those messages get out loud and clear to our patients, even if we never speak it out loud. So language is powerful internally and externally in terms of how we're communicating what we think is going on. So we got to back up a step here, though, because in order to do that effectively, in order to flip that script or even tune into what that script is, what are we telling ourselves about the situation? Where are the hidden shoulds? This patient should be okay. They've been taking this antibiotic and there's, nothing's coming up on the radar in terms of physical symptoms. They should be having more energy now. That's value judgment. So if we can clarify our expectations and our values and shift our internal interpretation of what we think is supposed to be happening, what's actually happening, what's the functional impact, and how do we operationalize all of that, we can remove value judgment and we can empower ourselves and others to feel better about what's going on. Then we're in a really great space to listen for patient language that reflects misunderstanding, unhelpful beliefs, interpretations, and then we can model flipping that script for the patients. And you don't need to be a psychotherapist to do this effectively, I promise. Thoughts or questions so far? I look at this stuff like this every day, so it all makes sense to me. But if I have said anything that, doesn't jive or you have a question, feel free to speak up.
So I do see a question in
Considered
our meeting
good
chat.
science, or is that considered bad science of categorizing patients, patients who are, I guess, bipolar or I don't, sometimes I
Yeah.
can think of, the house staff is saying that this patient's like is a complainer, but then are we categorizing too much, or how do we make it useful in categorizing patients? You said depression, and how would that differ from somebody else? And how functional can you get people to be or motivated to be? Is there a boundary which you shouldn't cross or
Okay.
I was yeah.
That was like 5 questions, but I love them. I love all of them, and they are interconnected. I think I'm glad you asked me because I am going to show you a model that I think works. And I'm going to show you how the sausage is made in that sense. With regard to categorizing patients, I'm going to be really radical and anti-establishment. I hate the DSM-5. I was trained to do the skid. I was trained to do psychiatric diagnostic interviewing and to algorithmically decide if someone meets criteria for a particular diagnosis or not, and what explains what more than what. And I think we need to throw that all away to some extent. But that's not where we're at in the world right now. So we work with what we got. But I think what you're hitting on, Dominic, is this really important idea that we're so tempted to put things into buckets or categories to understand. So what we're doing is we're talking about taking constellations of symptoms. And keep in mind that what we're tempted to pathologize as symptoms are probably byproducts or underlying processes of something else that's going on, right? Depression, we now more widely accept. This was a radical view even 5 to 10 years ago, but now we're getting closer to most mental health people being able to say depression is probably, because it's so heterogeneous or heterogeneous, if you don't like the British pronunciation, it's probably an inflammatory process from something else that's going on in the nervous system, right? And we see it on the surface as something that we call depression. So I'm going to be really radical and say, throw out your diagnoses. Yes, we need them for billing. We need them to justify payment for certain kinds of services. But what I really want to encourage people to do in flipping this script for ourselves and our patients is think about those constellations of things that you're tempted to pathologize as symptoms and start to look at them as functional adaptations to some stressor that may have unintended consequences, that may have counterproductive qualities to them, but all of which are probably meant to be adaptive. And if we want to give patients relief mentally, physically, emotionally, we're better off targeting our treatment to the functional impairment posed by that symptom than the diagnosis that we think that symptom represents. Does that make sense? I probably could have said that a lot more succinctly, but diagnoses only take us so far. We need them, and they're kind of garbage in a lot of ways. Sorry to say.
Yeah, so you're saying identify the more of the issue or the problem rather than try to focus on necessary to focus on categorization of the patient.
Absolutely. Absolutely. We can use diagnoses, for example, to justify payment for certain kinds of services, right? So I can't bill for my 90834 psychotherapy 45-minute sessions if I don't have a diagnosis like depression or something listed in the patient's problem list. But it's so imperfect, and that's part of what we're challenging here is this existing framework of pathologizing everything in order to try to make things that are more nebulous and probably more intersectional than we realize, more concise and able to control. That we do that out of comfort, I think. We do that out of a need for comfort and predictability, and the nervous system is not like that.
So I don't know if you saw the note from Renata. It says takes a long time to gradual things to show up as well to as dissipate in how these things affect us. Asking what may still be holding someone back or paused from moving forward. And it is possible to have normal lab work and still afford those labs to be abnormal, to be uh, for a person. And
Yes,
yeah.
I love that. I had this conversation with one of our residents actually earlier today, where I have a patient that is taking some antipsychotic medication for symptoms of psychosis. But that's actually not what's disturbing to the patient. What's disturbing to the patient is the weight that they're gaining from the medications that they're taking. And their psychiatrist is really focusing on, but this is the medication that we need to control those psychotic symptoms. And the patient's going, I get that that's important, but I have other ways to cope with the voices for now. I don't want to develop diabetes, right? So that's an example, right? Where someone can have a subclinical presentation with regard to their thyroid function and not technically meet criteria for where we would maybe want to start some medication. However, If that person can't get out of bed, they have no energy, right? They're having all of these other symptoms clinically that are really impacting how they feel about themselves, how they're able to function. We still need to collaborate and work with that patient to figure out how to target our treatment as effectively and safely as possible to the functional impairment posed by even things that don't show up on labs, right? Yeah, well said, Renata. Next slide, please. So I mentioned in order to empower our patients to think about what they're experiencing differently so that they can get to a place of radical acceptance of whatever the new normal happens to be, we need to check in with ourselves too. You heard me say it, right? Like I contradict myself all the time. I want to, in my notes, document patient reports having difficulty getting out of bed the first hour that they think they should be up, right? It's much easier to say hypersomnia, right? So that's how indoctrinated we are. So it does require some effort and some legwork on our part to just start tuning in and listening to what are we writing in our notes? How are we describing the patient? If we read that out loud, would the patient know what we're talking about? Would that sound like the patient's experience to them, for example? So it starts with us. So patient with significantly decreased energy, focus, and motivation following episodes of COVID infection. This is a real patient I worked with, was taking an atypical antidepressant. They were taking Wellbutrin or bupropion for a long time with minimal benefit. We had maxed out the dose and they weren't really feeling much better. And so we said, this is treatment-resistant depression, right? After a few sessions, some CBT, some cognitive behavioral therapy, which works for a lot of folks, I realized I wasn't perceiving much progress either. It kind of felt like we were still hitting the reset button every session. I looked back at my notes carefully and I focused in on that word motivation. And I realized that I was accidentally infusing that patients observed difficulty with what was neurological volition, really, the ability of the firing, the chemical and electrical firing to get the person from point A to point B and past that inertia, that neurological inertia that existed in their system as a result of very real physical symptoms. I was infusing that with some value judgment about their level of desire to get up and get going. I was doing that unconsciously. And once I tuned into that, I processed my feeling of shame about that. And then I thought, okay, how do I operationalize that? So I asked the patient, how would you describe this? If you were writing this progress note, how would you describe that symptom that I described? How do you think about this? Let's talk about that. Let's renegotiate that. Let's flip that script together. And doing that helped me identify. Then I was listening to the patient differently, and I could hear the discrepancy when they were saying, I know I should be giving myself grace, but I feel like crap about myself, like I'm lazy, I'm being so lazy. So then I'm able to challenge that and go, well, what does lazy really mean, operationally speaking? And we started to see a shift almost immediately, just in that one simple thing. Next slide. So how does this work? This is the model that you asked about, Dominic. It's neuroscience, it's integrative, neurosomatic, cognitive, dialectical, interpersonal behavioral CBT. It is not eclectic. CBT is often thought of as a discrete psychotherapy modality, and people treat it as if it's a monolith, but it's like calling all people who live in a certain part of the Asian continent Asian, right? People are of all different kinds of ethnic subtypes and groups, and that's based on so many different cultural factors. CBT is like that. CBT is not a monolith. It integrates and incorporates aspects of what we would call dialectical behavior therapy, popularized by Marsha Linehan's work, for example, interpersonal psychotherapy, Kaufman's work, classic cognitive behavioral therapy, Aaron T. Beck and his daughter Judith. And more increasingly, this recognition that in the mental health field, we can work on the mind, but if we are not working on the part of the mind that integrates with the rest of the nervous system and the body and the soma, we're missing a huge piece of the puzzle. So I can do cognitive behavioral therapy and help someone cognitively reframe their automatic negative self-talk. But if I don't help them figure out where that lives in their body and how to work through that and process that and do that differently, it's gonna feel like we're not getting so far or we're only getting so far, right? So what I do is I integrate, not eclectically blend, but I actually think about the parallels between these different types of submodalities And I integrate a core set of skills from each of them that relate to each other on a neurological level. And I've broken it down into about 8 modules. And so how I practice is module 1, I teach them about their nervous system. I say, hey, you have a nervous system that is finely wired for survival at all costs, even to the detriment of your happiness and mental well-being. This is neurological. So when you experience a stressor, like an illness that won't go away, an illness that has a lasting impact, like COVID, and it's not tangible, and there's nothing concrete that can be done to cure the actual illness or the cause of the illness, and you're left with this cascade of symptoms that are creating this functional impairment for you and changing your quality of life, that's on a neurological level. So your body is taking all of that information input and is trying to adapt. So the symptoms that you're tempted to say are problematic for you are actually meant to protect you or keep you alive. It's just that they have consequences too that aren't so much fun and that can really pose functional limitation. So the first module is usually just all about getting people to accept that. So that's part of the new normal is I need you to think differently about what you understand about your mind and body and how it works in healthy ways and unhealthy ways. And I have a whole set of skills. I've manualized this with lots of research behind it. So happy to share those resources if anyone has a bent. But I also work in residency training. So I'm very good at taking the core skills and distilling them into things that can be micro practices that you can do conversationally in a 15-minute medical visit if you had to. So all of this stuff is meant to be very accessible. I'm just giving you the theory behind it for now. So it might feel a little weighty that way. Module 2, I teach them, here's the magic formula. It's not so magic. There is a deeply rooted sense of who you know yourself to be based on what you think you're capable of doing, what you think you're worth to others, how you feel about who you are, all of the lessons that you've learned that jive with that or challenge that over the course of your life. And swirling around all of that deeply rooted system, if you think of like a tree with a root system, deep roots embedded in the soil and taking in the nutrients, there's a flow upward to the leaves and branches. And at the surface level, what we see are thoughts, feelings, and behavioral input. That creates a two-way response system. It's a feedback system for better or for worse. If I'm driving along in traffic and someone cuts me off at an intersection and I have to slam on my brakes and I'm worried about my child in the back seat, my initial response might be anger. I get a little ragey. Where is that coming from? That's actually being driven by fear. I'm afraid. What would have happened if I weren't able to step on the brakes so quickly? Would I have gotten injured? Would my son have gotten injured? And that creates this whole cascade of responding in my body, fight, flight types of responses. So everything that we think, feel, and do, or every interpretation that we make about what's going on around us, including our own emotional state and our physical state, has an impact in terms of what's going on in that root system. It interacts with that root system and produces all of these phenomena that we've been talking about in terms of behavioral responses. So there is such a deep connection between your thoughts, feelings, and behavior. And thoughts, feelings, and behavior are not often what people believe them to be. Thought, for example, is memory. The active process of reconstructing a memory from long-term storage, right? Because it doesn't exist in this compartmentalized place where we're like, oh, there's the memory. It's an active process of reconstruction. So when you start to think about what's going on neurologically with long COVID, for example, our thought process can really become derailed. Our ability to remember things accurately, quickly, effectively, efficiently, our interpretation can be affected. That is further informed by how we're feeling both emotionally and physically, right? So feelings are emotions, but they're also very much physical and they're often interconnected and influencing one another. And then behavior, something that happens and we respond to it, something that we do in response to something that's going on around us. Rain is behavior on the part of the climate or the environment, right? Crying is behavior. Blood pressure increasing in response to a stressor is a behavior. These things are measurable or observable internally and or externally. And so if we can start to tune into that and deconstruct that, we can redirect it. We can take it off of autopilot. And actually what we're doing is rewiring those connections. So right now, my typical patterns of thought, feeling, and behavior are on autopilot much of the time, like 99% of the time. And it takes conscious effort to stop, reflect on that metacognitively, do something different with my body, do something different with my thoughts or my self-talk to have a different kind of emotional and or physical impact. But it is possible. We sometimes call that cognitive reframing. And really what we're doing though is we're still leveraging some sort of interpersonal or intrapersonal effectiveness. This is why interpersonal psychotherapy comes in, because if we're not talking about the relationship between two people, we're talking about our relationship with ourselves. And so a huge part of getting patients to understand that there's a new normal, accept that there's a new normal, grieve the challenges that come with that, have to do with leveraging that relationship that they have or don't have with themselves and helping them build that in a healthier direction if it's not there. And then because meditation, Zazen, I'm trained as a layperson in Rinzai Zazen, so I never took orders. I did not want to become a nun, but I did get trained as a layperson to teach others how to do Zazen. There's great science behind this too. We don't have time to go into it tonight, but trust me, there's wonderful science behind this specific form of Zen meditation that has been done for thousands and thousands of years. And I even have instructions on how to learn how to do that too. Next slide. So what are we talking about? We're talking about cognitive and somatic processing. We can't change something until we are able to see it for what it is, break it down, process it, accept it, and figure out what we want to do with it. So processing is part of this larger kind of framework for everything that we talk about in cognitive behavioral work and all of those other related sort of integrative techniques that I talked about. And I already referenced this. Thoughts are images, self-talk, memories, beliefs, interpretations. Feelings are both emotional and physical, behavior being observable things, and they all interconnect with one another to inform and be informed by our underlying cognitive schema. How does this work? It rewires the brain through a process called assimilation or accommodation, and often there's a little bit of both going on. We don't have time to go into the technical mechanism of action underneath that, but that is the mechanism of action here, is really when we take in new information that is challenging to the system as it is, our body and mind has to figure out, does that make sense with what I already know to be true about what's going on in here? Does that match? Does that not match? And if it doesn't match, what do I do with it? Do I change what's going on in here to make that fit? Do I disregard that? Do I change that to make it fit? It's a dynamic process. So hopefully that point is. And William says Zazen. Yes. Is there a
Yeah, I think
question
you
about
saw it.
Zazen? What would you like to know about Zazen, William?
That's a term I'm not familiar with.
Yeah, it's a Japanese term for sitting meditation. So it's specifically a form of sitting meditation. So if you've ever seen a depiction of most forms of the Buddha, the Enlightened One, kind of regardless of cultural tradition, but you'll notice like often sitting in what's called a full lotus pose, like the legs are folded in a certain way. There's often a mudra or a hand position, a posture that is being used, and you see this very serene sort of countenance and being. That is often the physical representation of Zazen. So Zazen is a very specific way of sitting and meditating in order to produce awareness, insight, enlightenment, and transformation. That's a very crude definition.
Yeah. And then it looks like we've got another one. Why include Zazen specifically rather than other mindfulness-based approaches?
I think that Zazen encaptures a multitude of different kinds of mindfulness. Zazen is a form of mindfulness meditation. There are lots of different forms of meditation. So there's transcendental meditation, there's Pure Land Buddhism meditation, Nam Myoho Renge Kyo chanting. There's lots of different forms of meditation in different cultural traditions that are all aiming to get people on a path of connecting with their internal higher power for awareness, insight, enlightenment, and transformation. And mindfulness has become a much broader practice, right? So it's been sort of taken or distilled away from religious context and made more less about dissect of a particular religion or philosophical bent, and more about this idea of tuning in, being aware, accepting without having to change something in order to accept it, to begin changing it. So all of the things that we think about with mindfulness, the deep breathing, the focusing on what's coming up in terms of sensations, use of visualization practices, use of a mantra, for example, chanting or counting during Zazen, those are all mindfulness practices. So I specifically reference Zazen because I think it really integrates all of those different kinds of like mindfulness-based stress sort of practices. Hopefully that is a good answer for now. In other words, think about
That was my question.
and
Thank
try
you
to
so much.
integrate as last step. Yeah. Manami, I'm so sorry I cut you off. Please say again.
No. Just that was my question. And thank you so much for answering the question. That was very interesting. I'm Japanese and I know the name, but that was my question. Thank you so much.
Thank you. Thank you. Next slide.
Mr. Ware, he's put another comment in there. In other words, think about what is happening and try to integrate it as a last step, question mark?
Yeah, I'm not exactly sure what you mean by last step, but yes, this idea of finding a way to be present with whatever is without immediately having to change it, right? Because this idea of we're always rushing to change things, right? I don't feel well. I have a headache. Let me take some Advil or some ibuprofen and feel better. If I take the wrong medication, though, it might not give me relief from that headache. So if I first can sit with the pain momentarily and understand what might be driving this pain, when did it start? How is it making me feel? How do I feel about this emotionally? If I can tune into that underlying process, that sounds like a lot of work, right? But guess what? Your mind and body are doing that work all the time. We are constantly scanning internally and externally and trying to make sense of everything that's going on internally and externally, whether we're conscious of doing that or not. So you're not asking anyone to do any extra work. You're already doing the work, but you're just not dialed into how you're doing the work. So when we shift to dialing in and doing the work intentionally, we start to have a little bit more, I don't like the word control because I think control is an illusion, but we start to have a little bit more leverage with whatever the underlying processes are. So if I can take a second and not freak out that I have a headache, it's going to probably reduce a little bit of the inflammation, right? If I can lower my blood pressure, my head's probably going to feel a little bit better. And if I can answer or start to answer some of those questions, I wonder what is driving this headache. I have a much better shot at figuring out what to do to shift the pain that I'm feeling, right? That's not a great example, but it's kind of along that, yes. So trying to notice what is, sit with it, integrate it, not as our enemy, but as something that is a byproduct or meant to be adaptive or functional in some way that's causing us grief. Grieve that impact and then figure out what to do with it. We have a much better shot at that last part, being able to figure out what do I do now? So going back to that example of the patient that was having difficulty getting out of bed, that was calling themselves lazy, the patient describes. So this is where operational definition. So this is a very simple micro practice. Describe what is, what's really going on. I can't get out of bed in the morning. I want to be able to get out of bed at 6. My alarm goes off and I routinely can't get out of bed until at least 7 or 8 o'clock. And that's making me late for work and I'm getting in trouble. All right, that's an operational definition that we can work with. We can set goals and targets for change. And we can also start to understand maybe what is the underlying mechanism of action that's making it difficult to get out of bed, because laziness doesn't do a thing for us. Just don't be lazy. How does that work? I don't know. Recognition is that next part of the micro practice, right? Awareness and some insight. I recognize depression and decreased motivation as manifestations of loss of neurological volition on a neurological level, and I can educate the patient about that. So I can help flip the script, right? If I recognize that. So I can say something like, hey, did you know your nervous system is listening to you? So every time you call yourself lazy, your body is reacting to that as a trigger point, as a form of danger. It's negative self-evaluation. That's toxic. You've already got enough stuff going on physically. You don't need to be beating yourself up about this, right? So getting the person to start to realize that there's a negative impact that is complicating things for them by being so subjective about their definition. If your body can't do what you expect it to do, again, another operational definition that gets at lazy but isn't lazy, that can trigger a fight, flight, freeze, or fawn response. And usually I've talked to the patients about what those different response states are, right? So I don't expect them to know that automatically. But I'm like, your body, your nervous system is saying, we're in danger. I need to fight. I need to get out of here. I need to shut down. I need to protect myself somehow. That's going to make it even harder for you to get out of bed, by the way. And flipping the script. Is there some way that your body, however counterintuitively or counterproductively, is it trying to tell you something? Is it trying to help you with something, right? If you can't get out of bed, there's a lack of energy somewhere. And maybe your body's trying to conserve energy, right? That doesn't let you off the hook. We still need to fix how do we get you out of bed on time so you're not late to work. But if we can understand it without value judgment and try to look at it as friend and not necessarily foe, even though it feels like foe, that's going to flip the script as well. So this is just one of many possible micro practices, just starting to get operational definitions of things, observing what is, and then getting curious about, is there any other way to look at this that we haven't thought about before? Next slide. When I do CBT classic style, I teach patients how to use something called a 4-part processing worksheet, but this is a more algorithmic or like it's a little artificial in some sense, but basically what I'm saying, what's happening? What's going on? What was the context of the situation? What do you think was going on with your body in terms of fight, flight response or how you're adaptively coping or not coping? What are you telling yourself about this? What's popping into your mind? What are you visualizing? Are you picturing in your head your boss writing you up and getting fired from your job and being houseless and on the street with no way to feed your dog, right? Because that's literally the spiraling rabbit hole of doom that some of us go down on autopilot and we're not even dialed into it, but it is happening. And when we start to tune into that and make that clear and explicit, we can challenge it, right? We can look at those beliefs, we can look at those interpretations, we can stop the cascade down into the rabbit hole of doom. We can process our feelings and our emotions much better, and then we can figure out what's going on next. How did I deal with this? Did I deal with it effectively, not so effectively? And is there another way to think about this that would be more compassionate, more helpful, more constructive, et cetera, et cetera? So I usually do have patients take stressful situations or thoughts about symptoms that they're having from long COVID, for example, and actually start to record these. I do it in narrative form and discussion based first, and then I actually have them start writing because writing is magical. It allows different communication centers in our brain to operate simultaneously instead of alternately, which creates this insight and integration on a neurological level and strengthens the rewiring process. Next slide. So what's really happening? I refer to it as alchemy because I love romantic words and I find alchemy to be a very romantic word. But basically, it feels like a little bit of magic. It's actually science. This is a form of what some therapists have called fierce self-compassion and radical acceptance. Fierce self-compassion does not mean coddling. It doesn't mean making excuses. It doesn't mean letting ourselves off the hook. It doesn't mean we have to like what's going on. It just means that we're willing to look at it differently, challenge our assumptions about it in a way that could open the door for other possibilities for healing mentally, physically, and emotionally. So it doesn't mean we have to like it. It just means we don't have a shot in the dark at changing things if we're fighting ourselves over what we think, feel, and believe about what's happened. Denial, for example, temporary avoidance, but doesn't really get us very far in the long term, right? So acceptance doesn't mean we like it. It doesn't mean it's okay that it happened. It just means I understand that this has happened, that I can't change what's already happened, but I can start to think about how it's affecting me, and I can do something differently there. That little successive approximations over time are going to get me to a different place, and that is going to help me heal neurologically. And when I start to heal neurologically, the rest of my body has a much better shot at healing physically from whatever it's being challenged by. So it provides comfort. It is comforting and healing to the nervous system, which we know can help reduce things like inflammation, right? It can slow down the cascade of the cytokines. speed healing and recovery, and it frees us up. At the very least, it frees up a ton of mental energy to get creative about problem solving, because when we're in survival mode in our brainstem, our prefrontal cortex is not able to do all of the amazing things it can do when we're feeling at baseline calm, regulated as much as possible. And then we can start to shift behavior to feel even better. We can come up with solutions that might have a better shot of working. We can communicate to our providers about our symptoms a little bit more operationally in ways that help them fine-tune the treatment that we're doing to get better relief. Because we're so amazingly neuroplastic as human beings, we can literally start rewiring things in a healthier direction. It's small, it takes a lot of effort and time for the patient to do this work. It's simple and incredibly difficult at the same time, but the cumulative effect is super powerful. Next slide. So we're not going to do this because we don't have a lot of time, but you can go back and try this. Think of a time or share a time that something didn't go well. Pick something that you can hold space for as an example. Keep it a low-level example, like my silly one about the traffic. And ask yourself a few key questions. So this is another micro practice. How do I feel in my body? Is there anywhere in my body where I'm holding particular sensations? So for example, sometimes people tell me, I don't know how I feel emotionally. I don't know what I think. But they can tell me that they feel a wobbly feeling in the pit of their stomach, or they can tell me that it feels like their stomach has dropped out through their gut onto the floor. That sinking feeling. I've had patients tell me it feels like, when you're in an elevator and the elevator is about to drop and you lose your footing and you feel that momentary suspension of your internal organs. That's how I'm feeling right now physically. And I can say, I think that might be a proxy for fear. If there was something that you were afraid of or your body's afraid of here, what might that be? Can you think of anything that's been more stressful lately? Or, can we start to tune into that dialogue a little bit? So our body gives us huge clues that we either suppress with Band-Aid medications and not actual treatments. I'm not talking about actual treatment. I'm talking about self-medication with alcohol, for example, or other substances. We numb and subdue what our body is trying to tell us. And our body gives us huge clues about what's going on neurologically, neuropsychologically. So if we can start to tune into the body first and foremost and bring some peace to that and regulation to that, the cognitive piece comes in line very nicely. So I ask them to say or out loud what they're thinking, what their body's feeling, how that impacted what's happening, any feelings that they have. We go into the complexity of emotions because nobody is born in this world knowing how to feel shame, guilt, or belief that they're lazy. That's a manufactured emotional psychological state based on value judgment. So if we can deconstruct that, then we can really start to shift from that negative territory into more neutral territory. I'm not asking people to go from feeling like crap about themselves to Pollyanna sunshine. That's not realistic. But if we can gradually shift into more neutral territory, that's going to bring a lot of relief, a little bit at a time. Next slide. So in summary, I've taken a whole lot of theory and philosophy about this kind of practice and tried to distill it into a few simple bullet points, which is never going to do it justice. But the bottom line is all we need to do for starters is to validate. The new normal might feel really awful. We just acknowledging that out loud and processing any grief, allowing people to recognize that there's grief associated with that and hold space for that. That feels awful. It doesn't feel good to not be able to get out of bed in the morning and to be worrying about the viability of your job as a result. Reflecting on our own beliefs and language puts us in the best position to help our patients do the same. So when we say, how do we get patients to accept? Let's do a little work internally first and make sure we're on the same page with ourselves about what our expectations are here. A great example of that is you're treating a patient, you're doing your best, and the patient's not getting much better. Most of us were drawn to this work, whether it's medicine or psychotherapy or something else, because we want to help people. We want to heal. We want to help people heal. And we take on a tremendous sense of responsibility for making things happen. If I can diagnose the condition and find the right treatment, I can help the patient get better. And it's not so straightforward and simple when it comes to long COVID. So we really do have to check in with ourselves and make sure that we are on the same page internally with ourselves about what we think and feel and believe about what's going on here, all of this. Our nervous system pays close attention to what we think, feel, and do for survival purposes, and it responds in ways that are meant to be protective, but that can be really counterproductive at times and further contribute to our limitations. So understanding that mechanism of action is kind of the key to a lot of this. And we can't change a darn thing unless we address all components of its manifestation: cognitive, somatic, body-based, behavioral processing. It can reduce the burden on our already overtaxed nervous system, physical system, to promote healing. And we can coach people to recognize that, tune into it, and leverage it in those small but cumulatively powerful ways. Next slide. 2 classic references. Got to break out the old Beck. But this is his daughter, Judith, with a slightly spin. She's a neocognitive behavioral therapist. And there's a great article that I was able to find on psychotherapy in patients with long post-COVID. It's a systematic review. Again, it's going to tell you that CBT is the thing to do, but it doesn't tell you what kind of CBT. And that's exactly what I hoped to provide a little bit of context for. And then this idea of the neuroscience of self-compassion. There is so much good emerging brain imaging data on what happens when someone practices meditation with the goal of accepting what is without being able to change it immediately, that leads to change over time. And the rewiring that happens. I wish we had fMRIs for everybody doing integrative psychotherapy so we could show how amazingly effective it is. But the bottom line is that, in addition, what every single research paper will tell you is that the thing that is most predictive of change for patients is the relationship that you have with your patient and the relationship they have with themselves. So in order to help others regulate optimally, we got to be checking in with ourselves first and foremost. So how do we get patients to accept what's going on? We have to work on what that acceptance means within us first, given our role in that relationship. Thoughts, questions? We have just a few minutes left. I'm so sorry. I'm also open to emails, so if you have questions that we don't get to today, happy to find a time to hop back on a Zoom informally and chat more about any or everything that I mentioned. I'm looking at the comments. I'm an allopathic physician, not a psychiatrist or family therapist, and while I feel that thinking and talking are important, I also feel strongly that the healing touch is also an important part of any. Yes, I love that you brought that up, William. There is a lot of controversy around this idea of healing touch, but if we think about it, if we go back to very basic research on attachment and bonding, Thomas and Chess talked about temperament, and there was John Bowlby, behaviorist, took monkeys, poor little monkeys, and some monkeys had a cloth monkey and some monkeys had a metal monkey, and the different monkeys provided different levels of emotional, physical, and actual food-based nourishment. And they showed that attachment and bonding, the need for human beings to survive by having connection emotionally, physically, and spiritually with other human beings is so powerful. Those little baby monkeys would get the food and then they would go cuddle with the fabric monkey that wasn't able to give them food because that bonding was really important. I'm grossly oversimplifying and misstating the original research, so forgive me for that. But the point is, we are wired for survival through connection with others. We regulate. You can feel it, right? If somebody walks into the room and they're angry, you can feel that, right? There's actually a chemical and electrical signal to someone's energy. The heart, for example, we know that the heart has its own nervous system that is semi-independent at times, functioning from the brain as part of the nervous system, right? They're obviously integrated and connect. But that's why someone walking into the room with anger, we can feel it. It's almost palpable. It almost feels physical. So yes, touch is very powerful, but I would also argue that when we are in proximity to other people, depending on how close or how far we are, we're actually overlapping in electrical fields. They're measuring these now. It sounds like science fiction, but it's actual science. And that influences. So if I have someone really dysregulated in front of me and I say, calm down, guess what's going to happen? I just poured a whole bunch of fuel into the fire. But if I can check in with myself and go, whoa, that person seems really upset. I don't think this is about me. I'm going to take a deep breath. I'm going to open my body language. I'm going to accept that they are feeling really distressed for some good reason. Yes, this has to do with auras, Renata, absolutely. And I can regulate. Guess what's going to happen with that other person? They're going to start to dial down a little bit. And that's not behavioral, that is neurological. That is co-regulation that's happening with our mirror neurons in our brain in response to our survival system. So touch, and I would argue that touch extends to a certain physical distance when we're in the presence of other people. So much more I could say about that, but I don't want to get too woo-woo about it right now. Many of our individuals are lonely, use of AI. Can I recommend AI services that are safe to use without hallucinations or hurtful? That is like a whole talk for another day. I have mixed feelings about AI when it comes to psychotherapy. Because of the neurological component, so far with the AI we have, it's not possible for that same regulation process to happen. AI has a bias toward false positivity. So it has a bias toward telling people that things are better than they actually are. I can give you so many examples of this. I've thought about starting a blog. I actually did a deep dive one Sunday at 3 o'clock in the morning when I couldn't sleep with AI and talked about whether or not there's any purpose to human existence. And by getting around some of the commands and presenting as a depressed personality type, I was able to get AI to agree with me and say, there's absolutely no purpose for any of us being alive, and we're probably better off giving up. It didn't tell me to kill myself, but oh my gosh, can you imagine if I were feeling suicidal and I was looking to that for confirmation? So there's a lot of concerns. A lot of the standardized programs and software that is designed for CBT, online, or therapy, their avatars, they're far from perfect. They can be really good for building skill set and practicing the skills, but I still think they should be used with guidance from someone who has been trained to understand the human nervous system. I feel like more people I talk to who have long COVID are accepting of their situation, but they are more struggling with others not believing them. Yes, that's that stigma that we talked about in our first session back in October. That is very real because, again, like I mentioned, a lot of this is invisible or not easily measured on the surface or externally. And we're all riddled with value judgments and biases. How in tune we are to those makes or breaks what we can do to work toward this acceptance. And so as a field as a whole in healthcare professions, we still have a long way to go in terms of trauma-informed care and getting people to understand the adaptive survival mechanisms that drive what looks like pathology and how to embrace that and leverage that for positive change. So much more work to be done there for all of us, including those of us that have been reframing things cognitively for 20 or plus years. We're still prone to bias. I'm a physician researcher, but I'm a long COVID patient at the same time. 5 hospitalizations. I'm so sorry you went through that. That is intense. Yeah. Yeah. The struggle is real with that. So much more that could be said. I know we're out of time.
Yes.
Feel free to email me at any time. I'm happy to have informal conversations about this more. If you have questions about particular patients, if you have cases, a hypothetical that you want to run by me, so happy to help you think through some of this stuff, what kind of therapy might be helpful for your patient and how to get them connected.
Yeah. So, and then, so just so everybody's aware, well, first of all, thank you, Cynthia, so much. There was so much good information in there. So if anybody would like to reference back to her slides, they are already up on the IOCO website. So even if you just want to reference her email address, it's on that final slide there.